Hello and welcome to the MOASC Clinical Webinar. My name is Nicole East. I'm the Executive Director of MOASC. Thank you all for joining us this evening, especially those that joined us all the way from Korea. As you know, one of MOASC's goals is to provide ongoing clinical education through monthly webinars like this. In recognition of the upcoming Melanoma Awareness Month in May, we will be discussing melanoma patient engagement. I'm pleased to introduce our esteemed presenters tonight. First, we have Dr. Sherry Hsu, Cutaneous Oncology Lead for KP National and SoCal Kaiser Permanente, co-lead for the renal cell carcinoma and melanoma program for Kaiser Riverside. Second, we have Dr. Gregory Daniels, medical oncologist with a focus on melanoma, skin cancers, and thyroid cancers at UC San Diego Health. He's also a member of several local teams with the mission of advancing immune therapy. And we also have Dr. Andy Jang, UCI professor, intralesional program lead at Kaiser Riverside, and then co-lead of the renal cell carcinoma and melanoma program at Kaiser Riverside as well. So without further delay, I'll turn it over to Dr. Hsu.
Hi, thank you, Nicole, for organizing this exciting event and webinar. And thank you for giving us a good, wonderful introduction. It's good to see KP oncologists collaborate with UCSD oncologists in this format. I do hope to continue this type of collaboration further in the future. And Dr. Daniels.
Yeah, no, I'm looking forward to tonight's discussion as we kind of talk about clinical trials and how we all adapted to COVID and not adapted, and then the emphasis on some of the stuff you guys are doing at Kaiser. Looking forward to hearing about that.
Yeah, thank you, Dr. Daniel. So I move on to agenda and the objective of this tonight's discussion. We'll begin with a short updates on institutions, research, and trial that's open or recently closed, and quickly move on to a group discussion about our practices and patient care, how it changes and adapted, like what Dr. Daniel said, during the pandemic, and how some of us would like to keep these positive changes to improve patient experiences in clinic. We'll follow this discussion by a introduction to special programs in both centers. I will introduce the intralesional injection program, and Dr. Daniel will introduce TIL and the ex vivo program. We can compare these two institution practices and see how we provide patient care from A to Z in terms of from the start of the treatment to the end and the follow-up and to the data collections. Finally, our final speaker of tonight will be Dr. Jang, who will present the latest exciting clinical trial data in neoadjuvant and adjuvant settings for cutaneous melanoma. He will lead the group discussion of these data, and we'll end with, at the end, a question and answer session. The objective of tonight's discussion is mainly one, share current practices in evidence-based medicine to identify areas for clinical trial and virtual care improvements. Number two is we try to integrate the latest new therapy to improve quality of care for patients. And our last objective is to discuss management plan for patients by appropriately using available treatment in the neoadjuvant and adjuvant settings. Begins tonight's discussion about KP's clinical trial research setup. As you can see in the slide, there's many decades of history of KP research. I want to point out that in 2014, the NCI decided to support and fund a community research program. Unfortunately, KP was able to secure and receive one of the 46 NCORP sites. This allowed KP to unite our KP regions together. There are currently 67 KP facilities across the nation who are collaborating partners in the KP NCI Community Oncology Research Program. So this allows 7 regions across the US, particularly in 6 states, including KP Colorado, KP Georgia, and Hawaii. We can collaborate, come together and support and collaborate each other throughout the nation. Currently, 11 million KP members now have access to KP trials. So I would like to thank all physician and patient and the team and support staff who have participated in our trials and help with the patient enrollment and recruitment. One of the newly closed and the data is recently available, is the new practice changing data presented in S1801. Dr. Jang will go over some of the details of this trial in the last session today. S1616 is a second-line metastatic setting trial that studied ipi-nivo and showed the improvement in progression-free survival as compared to nivo single agent. It showed that for those patients who do not respond to PD-1 alone can be rescued with the combination IO therapy of ipi-nivo in the second line. Checkmate the 76K. The purpose of the study is to determine the effectiveness of nivo adjuvant immunotherapy compared to placebo after complete resection of stage 2BC melanoma who are at a high risk of recurrence. So this is an adjuvant trial. Not all trial ended with a happy ending and the positive results. We opened the BEMPEG adjuvant trial that was quickly closed early due to the lack of efficacy of this agent in stage 4 metastatic setting. I'll just quickly go through the currently open trial, or one of the surgical trials opening soon in KP. So now that patients are living longer with stage 4 melanoma, we offer trials that focus on survivorship. 2 studies that are available that we can we present to our patient and keep in our mind when we see the patient in our clinic, that can provide some of the insights to survivorship. Our first one is a PETA-STOP trial. We studied the early cessation of melanoma treatment. We now know that treatment has side effects. What do we do? And when do we stop treatment? Is it after 1 PET scan or 2 PET scan? We like to learn just how much treatment a patient should be getting. In the S2013 I-CHECK-IT trial, also evaluate the toxicity pattern in patient receiving immunotherapy. It's an observational study. A patient will still receive their treatment as they normally do in their local center. The ipi-nivo plus growth factor GCSF trial is still open in our KP centers. It's used in first-line metastatic setting to see if a growth factor reduce toxicity and or increase efficacy when used together with ipi-nivo. Okay, and another trial, MOASC surgical trial, is about to open soon in our Northern Cal KP. It is studying how much resection margin a patient should undergo. There is evidence that maybe sometimes less is more. Less radical margin of resection may be just as safe as more. So patient will be randomized to 1 centimeter versus 2 centimeter margin. And the reduction in margin is expected to improve quality of life for patient, especially in like those functional area. I believe this trial also include a head and neck patients in those like functional areas. HBI 8000 study a high DAC inhibitor in patients first line metastatic setting, or I think they allow BRAF positive patient to be used as a second line. it shows a good activity. The drug showed good activity as a second-line drug, so now being studied as a first-line. A few years ago, we see the DreamSeq trial data presented in ASCO Planetary Series. It's about sequencing of immunotherapy and target therapy and see which sequence is the best for patient. One of the most important data that's shown by the study is ipi/nivo followed by target therapy associated with greater overall survival at 2 years. It's better than the target therapy first. Okay, so this study, the accrual, as you can see in the yellow, is highest in California, and that is a majority of that excellent patient accrual enrollment is due to Kaiser Permanente and Corp participation in this trial. I sometimes go to the national meetings and the trial PICs know my name, but they don't know me because of the signatures on these patient enrollment forms and follow-up forms. So it is recognized that diversity of ethnicity is the strength of KP, and we really do reflect the diversity and ethnicity of our patient population. NCI, ECOG, and ACRO research group has recognized KP as the ability to look at patients with diverse background. I will move on to have a group discussion with Dr. Daniels and Dr. Jang. So maybe Dr. Daniel, I'll give the first question to you. How did the pandemic impact the way we conduct our research? We recently passed through a tough time with the pandemic. What are some of the struggles and maybe hurdles that your team went through?
Yeah, I was thinking about this, and I stopped listing stuff after about 10 things that changed. Can you hear me okay, Sherry? Because I hear
Yes.
feedback. Okay.
I hear you very well.
Okay. So, when the pandemic hit, I think there was a lot of different reactions. Some sponsors put everything on hold for a while. That took maybe months, 6 months, and some sponsors to figure out that it was okay to keep going on the studies. It slowed study enrollment down for sure, which was a challenge for meeting endpoints on studies. It increased costs for people doing the studies. We experienced, the stress, lost a lot of people. I think we lost like 40% of our clinical research staff that were supporting trials because of things. And then we started having to compete for resources, whether it was, nursing infusion room areas, because we had to adjust, patient density. Hospitals got over full, patients were really sick. So some of the trials that we were doing, we didn't have hospital beds to do that in. So really a lot of challenges. And then on the flip side, it did open the obligate door that we had to figure out, well, how do you consent somebody that you can't meet with? So remote consenting, all of a sudden we were going to switch over to, better integration of our EMR, and now boom, all of a sudden we're doing a lot of visits over remote medical records and doing remote consenting, remote monitoring. That had to get worked out and put in place. So, we stayed open the whole time. I don't know about you guys, but it was definitely a pretty stressful experience.
Yeah, so I agree. In a way, the research needs some rigidity and regulation so we can have valid results, But I think the remote consenting and virtual follow-ups visits that really video visits for follow-up really helped us. And some of them we would like to continue. I remember filling out a lot of forms because of that. because to allow exceptions for video follow-ups. I remember doing that or hearing from my research team that they had to do forms regarding that. And what about the dispensing of the trial drugs, more mailing to the patients rather than they come pick up?
Actually, we kept them coming in because most of our trials, at least the ones I was involved in, we had to see them on day one anyways to do a check, and those involved usually blood tests, and we weren't doing those remotely, so patients were still having to come in and getting blood checks.
Dr. Jang, do you have any challenges or hurdles that you have to go through with your research patient during the pandemic?
I think during the pandemic, I think, it's not only it's hard for us to see the patient, and also patient doesn't really want to come to the clinic. So a lot of follow-up patients, you need to have a face-to-face, end up not coming. So we ended up having to do like remote, and sometimes it may not be as ideal. The question about how do I explore trial options in certain locations, I think personally, I think for us as a KP, to have a broader network of connections, to me, is crucial. As you know, I not only do the melanoma, I also do the lung cancer. So, like you and Gray has the consortium, me and Hatan Hussein, we do the lung consortium. Also knowing a lot of investigators at different institutions is crucial. The reason why is a lot of times when we refer the patient out, they are either not eligible, or there's a lot of different kinks. Sometimes make the referral unsuccessful. But by having a direct communication and knowing our experts and various institutions, that really help us to refer our patient for clinical trials.
Yeah, that goes nicely to our second question. Dr. Jane, what do you tell a patient who is interested in a clinical trial today? Like any recommendation, like talk to a oncologist, go online, see if, what do you tell them? What do you prepare them, like the timing of the trial and all that?
Well, a lot of time I either I prepare ahead, or I do my homework ahead. For example, like if I see the patient who might fail second or third line therapies, I may, sometimes I just don't even have to call the provider, or I call like Ignatius or Hatem in UCSD or UCI, and I just tell them, okay, do you guys have any trial in this kind of patient, so on and so forth. And sometimes they just directly tell me yes or no, and then give me a little criteria, and then I say, oh yeah, there's a trial there for you. I think I know this doctor there very well, and things like that, and then I make the direct referral. And a lot of times it saves a lot of administration hurdles, a lot of kinks, and also the provider from the from the referral institution already anticipate the patient coming, so it makes the whole referral process a lot better.
That's great that you have all these areas or avenues of connection with the local oncologist. So I prepare the patient and say, first of all, not all studies are offering all the places. It's worth your time, our time, to look around for options. And also, trial can open and close quickly. If you look at keep in mind that if you look at trials a couple of months ago, it may not be open right now. And Dr. Daniels, I'll give you the third question. What are some of the promising trials that you would like to see, or question you would like to be answered in a clinical trial setting in the future? For example, like biomarkers, sequencing, second-line treatment options.
Yeah, I occasionally am asked to predict what the next best thing's going to be, and I'm not very good at it. So what I've learned is I'm not great at picking the horses here. There's so many good ideas, but the reality is, unfortunately, most of them come up with some limitation along the way. But what I am hopeful for, like you said, biomarkers. Currently, most of our biomarkers are, static. They give us a picture at that particular biopsy or that particular moment. Where I think the answer is going to, or some more answers are going to come, is really figuring out how to dynamically monitor patients and their responses to therapy. And so, just like you have the PET stop program where you're, giving some treatment, making a decision early on based on a scan, I think those type of things where we start to get that biological input once you start pushing on the tumor, um, there's hopefully soon technologies from monitoring serum and getting at the transcriptional profile of the tumor while you're treating them, and watching those adaptations. So that's where I'm looking kind of for the next great thing, because there's so many tools that you're going to talk about, some intralesional stuff. We got a lot of tools, but the problem is how do you apply them to which patient, in what order, in what combination? And so that's where I think dynamic biomarkers.
Dynamic bound, and also in addition, it's sort of hinting toward like a personalized approach
Yeah.
in adjuvant setting, metastatic setting, when to stop treatment. So we're lucky enough that patient living long enough to talk about that. Okay, so we already discussed our last question. I can move on to, let me take a look. Okay, to the next session, which will be intralesional and ex vivo special treatment program. Alrighty. Okay, great. So it's a mouthful, the name. Telemogen leherperovic. It's an oncolytic virus injected to tumor cell. I'd just like to discuss this type of treatment today with a focus on KP Riverside program experience. It is a live attenuated HSV-1 vaccine, not HSV-2. The manufacturer scientists insert a few genes into the virus and remove a few virulent genes. So in a healthy cell, it's unharmed, leaving the cell unharmed. If it infects a cancer cell, hopefully oncolytic virus lyse the cells and release antigens, including tumor antigens, and then it attracts dendritic cell. Hopefully it will also not only shrink the tumor and destroy cancer cells in the local area, but has some achieve some systemic tumor regression in the sites that's not directly injected. Just some timeline. I find it interesting that NIB is the target treatment and everything ends with MAB is the immunotherapy treatment, and the telemogen T-VEC oncolytic virus is topic of today's discussion. Some quick interesting tidbits on history. This is not the first time we have intralesional injection treatment. Cooley's toxin is one type and BCG virus is another type. Some side effect T-VEC is generally very well tolerated. Maybe the first injection has some mild flu-like symptoms, fever, chills. In the original study, the durable response rate is 16%. Later updates show that it improved to about 19%. And then the 29-30% of durable responder had a complete response. The median time to response is 4 to 16, 17 months. Later updates showed that the median overall survival in 2019 updates show that it is slightly better with the T-VEC group versus essentially a placebo group, which is GM-CSF group. We preferably find some superficial areas of injectable sites, preferably can be seen by either physical exam or palpable. It is approved in stage 2B, 3B, 3C, and stage 4 diseases. These stage 4 disease does not have organ metastasis, mainly again palpable and found on physical exam or nodal lesions. Okay, I will move on. Sometimes we find the easy to inject sites, but in the deeper side, if a patient has a lymph node, we use ultrasound often in our clinic, in our procedure room to access lymph node for injections. In KP, we have the Health Connect, KP Health Connect electronic record that we can pull data, such as when is the first injection, when's the last injection, when did we order the medication, and what other concurrent or sequential therapy patient has received prior or during injection. In our early data connection show that the most of our patients stop the injection in about 4 to 6 months. Prior to pandemic, we have about 80% response rate. Some of complete response, some of our patients achieve a complete response. This is higher than the Optimum trial data, which led to the FDA approval. This response rate is higher. In other centers, real world data also showed about 80% response. In this published paper, showed 43 patients from 2016 to 2019. Many of these patients are already on the systemic immunotherapy as well. So some of our clinical pictures, example of patient response in the bilateral post-auricular lesions. This patient achieved a complete response at the end, verified by surgical biopsy. It's a good prognostic sign when you have an earring that's later on bigger than the tumor. Neck is easy to inject. This is a very 80-some-year-old patient on presentation, had multiple neck surgical resection, and eventually become not practical to continue to resect. She achieved a complete response and recently celebrated 90th birthday. An easy site to inject in the right thigh area. Amazing response in the scalp lesion, completely flattened out after a few months of injection. And another accessible site in the right neck area with a good response. This patient eventually, lesion completely flattened out. We have to use this ultrasound guided injection in the deeper lymph nodes. Another easy accessible site for injection. Some of our patient has more than 4 to 6 lesions in one extremity and become not practical for surgical resection. So these are excellent TVAC candidates. This is a very pleasant young lady, came in with a huge thigh mass or single lesion, and it's painful to sit on. Eventually she developed even vertigo around the injecting area. Achieve a complete remission. This is confirmed by surgical resection of the scar, and now off all treatments. So some other ways that they tested the utility of TVAC is combined with immunotherapy, like mimic the real life situation. Unfortunately, this study has great intentions, but failed to show significant PFS and OS in a master key phase 3 trial, although you can see some tendency to improve the median overall survival compared to pembro single agent group. And I remember participating in this trial in our center as well. Injection into other sites like liver for other type of cancer, HCC, is also being explored, and how to convert the hard to treat areas such as liver, convert the cold tumor into hot tumor with immunotherapy. So in also exploring neoadjuvant setting, as well. And Dr. Jang will discuss this exciting data further in the last session. Now there's a more later exploration of the concept of a vaccine, and this is the use of personalized mRNA cancer vaccine. Patient received total like 9 doses of vaccine, and pembro up to about 18 cycles. This trial showed the risk reduction of recurrence in the adjuvant setting. So what we learned in our experience, sorry about this microscopic font, is pre-pandemic already have 3 doctors set up, so patient does not get lost, and still have coverage of every 2 weeks scheduling, during the injection treatment phase. We have paper charting with labeling of the injection site. We have electronic tracking records, a pharmacy workflow set up for the timing of T-VEC retrieval, like defrosting and the injection. So during the pandemic, we have developed more robust virtual consultation. We save patient travel time, to use our virtual consultation to judge who is a good candidate and who's not. We developed our virtual video follow-up, into a better way to follow up, and of course cut down patient traveling. We do follow-up with scans done. Patient have these follow-up scans done in their local centers. We're also able to pull our electronic data and collaborate with other sites, KP sites that offer injection program for further data analysis, and more patient data for analysis, and maybe come up with the hypothesis generating questions, right? And area of need improvements. So we also identified that during pandemic, our assistants tend to, some of them are sick, sometimes come and goes. We need more people training how to support our injection and ultrasound use, and the workflow between our local oncologist and surgeon near the completion of treatment needs to be better thought out, because once you're have almost achieved a very good response or complete response, you would like to confirm sometimes with a biopsy to confirm the response, right? Anything else? And also we're fortunate enough to have a lot of support and subspecialty. When we need to ask for assistance, we can ask for help from our other local center specialists regionally, and ask nationally for help. So I'll turn the table to Dr. Daniels regarding.
Dr. Shu, we actually have a question that came through the chat.
Okay.
So it says, how many patients do you estimate have you treated with T-VEC and pembro?
Estimate, I would say 60% of our patients that we treat is have either concurrently or prior to injection had been treated with immunotherapy. Dr. Jang, would you agree?
Yeah, that's about right. Sometimes, their primary oncologist on their side started the IO and then started the T-VEC here. I would say 60% is probably the right number, approximately. Yeah.
Yeah. I mean, total nationally, I would say from Southern Cal and Northern Cal T-VEC Center, about maybe 200 patients we have treated with T-VEC. I think I believe that's accurate as assessment, and the 60% of that. Yeah. Yeah. And Dr. Daniel, were you able to share screen? We can answer the other question while you're sharing. Another question is, are you that's from the past presentation. Are you all still allowing remote consenting? I think we're doing less of that right now, post-pandemic. Dr. Jang, did you do a remote consenting recently?
No. I think now it's pretty much live.
Back to in person, right? Yeah, we'd like to keep that, some of it at least.
Okay.
Mhm.
That's an amazing amount of TVEC you guys are giving. I
mean overall, like from the beginning, since the approval.
No, I hear you. I do find it definitely is active, and maybe I don't give it enough of a chance to use it. I would say that I probably only use it in 2% of all advanced melanoma patients seem appropriate for TVEC, but it's interesting how much you guys are using. So I was just going to talk for a second on TILs. Thanks for giving me this opportunity. And I'll start by just introducing our team. So Dr. Park is our disease team leader, along with Dr. Baumgartner. And Sue sees all cancers within the skin team, but predominantly the non-melanoma skin cancers. And Joel's in the GI group, but is one of our main surgeons doing melanoma surgeries. And then there's myself. And just to put a perspective on there, as Sherry mentioned, immune checkpoints really changed the field of melanoma, and Kaiser and other places have put immune checkpoints in the front of care for patients. But as the last follow-up from the 067 study showed, that there's still patients, obviously, that don't respond up front or progress after a while. So despite having pretty good results, they're definitely not perfect. The other issue is some of the toxicities that come up. So what are the options for patients who progress on PD-1 therapy or PD-1 based therapy? And it looks like in 2023, maybe 2024, it's kind of like the Cybertruck. We never know when it's coming, but it looks like TILs are coming. What I'm going to go through is just some quick data, not done in the US, but over in Europe. But one of the more recent publications on TILs. And it's relevant because this is where our big need is. So most patients in this study had prior exposure to PD-1 based therapy, although that's about it. They weren't allowed to have more than one prior systemic therapy. Of course, they were also fairly healthy people. So as we know, TILs is, we'll get into it, a little bit stressful therapy. And there are some of the key exclusions, which is also still an unmet need, are those patients that are over 75, that are a little frailer, or who have brain metastases. Those kind of groups were not addressed in this TIL protocol, nor in most of the work that Dr. Rosenberg really pioneered out of the NCI. So in this study, it was a randomized study to ipilimumab for these advanced patients, looking at TILs as the alternative. And there are the patient characteristics. And of course, that's too much to look at, so you can just get the primary reference. And for the progression-free survival, which for immune therapies is what we all try to do, give a treatment and then not have to give any more treatment. So TILs is a one-time autologous therapy. And here you see in PD-1 refractory patients, approximately 30% of the patients obtaining a benefit. And this number, although, you know, this was, again, a relatively small group and early, is consistent with pretty much all the other published cellular data out there for this type of treatment. So young TILs, these programs that can resect tumors out and generate TILs and give them back seems to salvage about 30% of the patients. The toxicities on your right side of the screen really aren't hard to see. But again, I refer you to the publication, and I'll just comment that there's toxicities in every part of this treatment, whether it's surgery, lymphodepletion, the TIL, cellular product infusion, and the IL-2, the bolus IL-2 that has to happen afterwards. Those are kind of the medical realms, but on the patient side too are, just the complexity of something like this. Just thinking about a patient coming in, trying to coordinate a surgery, waiting 3 to 4 weeks without additional therapy, at least during the clinical trials, that's what we had to do. And then waiting to hear back whether you got the cells or not. Of course, this is a commercial product, hopefully soon. So there's going to be a cost associated with it, but there's also the cost of running the programs, which really need to be a coordinated team approach. So how do you do that? Well, the first products, again, we anticipate will be in melanoma that are refractory to standard therapies. So they'll come through our disease team, screened that way. But at UCSD, we are a site for CERM, and we have an alpha clinic. We also have a cell processing lab. And so the cell processing lab and the alpha clinic got together and created the Cell and Regenerative Medicine Service, which is a hospital service where we do our early phase cell therapies and early immunologics that require inpatient monitoring. And so the way we're setting up to do TILs at UCSD would be patients will be screened through the disease team, and then once identified, we'll have the cells delivered by pretty much a medical oncology team. Bone marrow transplant teams could be an alternative, but we chose to, again, develop our own separate cell therapy team with staffing that includes advanced practitioners who are involved in bispecific antibodies for solid tumors, managing toxicities for CAR T cells, and all the things that go along with the cell therapy. So as we anticipate, hopefully towards the end of this year, we'll have a commercial product that's available. Then this will be the pathway where we have patients coming through. So I didn't really go through a lot of data, but wanted to leave it if there are any questions about kind of TILs and where they fit in. Let me stop sharing. Let's see.
So there is a question that came in through the chat. Can you see that?
Yeah, that's another Dr. Park, my disease team leader, is asking me who I'm going to give TILs to. So the right patient for TILs, in my mind, is that patient. As I said, there's a lot of aspects to TILs. So you have to have an accessible tumor to take off. So if somebody has bone metastases or hard to reach tumors like an adrenal met, the current technology, you need at least 15 to 20 millimeters of viable tumor tissue to come out. So an ideal patient would be somebody with lymph node or skin lesions where recovery from surgery is quick. Next thing is look at comorbidities because they have to be able to tolerate lymphodepletion and be neutropenic for up to 1 to 2 weeks. Be of the fortitude to tolerate inpatient admission for 2 to 3 weeks. We anticipate we're going to be doing lymphodepletion as an outpatient, but that takes a patient who's reliable and follows up. And if we're going to do this in the outpatient setting, and then admitted to the hospital for bolus IL-2. And bolus IL-2 is those that are old enough to remember, can have its own toxicities of cytokine release syndrome. So like, there's a lot
Dr.
of,
Daniels, what is,
Yeah.
I remember doing high dose L2 as a first line treatment when there is no outpatient immunotherapy in the dinosaur age. Sometimes we, had to cut it short, and because of toxicity, the 6th dose of high dose L2, number one is what my question is, what is the logic behind that? And number two is do you often have to cut down the doses?
yeah.
Mhm.
Yeah, good question. Yeah, I'm a dinosaur, so I have given IL-2, and we still have some protocols. For example, we participated in the Iovance protocols here and had to give IL-2. And as you're alluding to, they cap the number of doses of IL-2 rather than the old days of dosing till everybody got scared.
Right.
You dosed to a fixed number of doses, and that's based on data out of the NCI, not anything that was done as a randomized study with the commercial product, which is based on Dr. Rosenberg's work. But looking at the NCI data, the average number of doses that a patient got and maintained a response was 6 to 7. And so they took that and capped it, thinking that from a practical point of view, it's better to do that kind of therapy rather than deal with the potential for having a lot of extra toxicities. Because with bolus IL-2, it is relatively immune suppressive for neutrophils, but now you have neutropenic patients getting IL-2.
Yeah.
There's certainly toxicity risk. That's a whole area. That alternatives to IL-2 to support the cells, whether you're modifying the cells, so with transgenes into the autologous cells, or alternative cytokines to try to get around bolus IL-2. Right now, it will be bolus IL-2 for the commercial product.
I think
So,
we.
I'll just say back to Sue's question,
Yeah.
who's the optimal patient?
Okay.
It's not for everybody. But it's a great one for a referral center to run because it's going to be that unique patient that's right for TILs.
I'll just follow that question to, I skipped the first one. We already talked about 2 programs and essential staff that keep the program running. So what is the referral process to your, if they're outside of UCSD? If inside sounds like you have a cell therapy team, right? They contact one of the team members, right?
Yeah.
Outside of UCSD, what's the referral process if they interested in TIL?
Well, with TILs, they'd contact our disease team, and obviously, if it's a provider, they can just reach out directly to me or Dr. Park, and we can talk about it. I think that's the most expedient way. I anticipate that Iovance is going to have a program to help kind of screen patients and identify centers where cells can be given. So the company, I'm sure, is developing a program for referrals too.
Yeah. Dr. Daniel, so I'll talk about the how our data in KP is collected and managed, both through mainly electronically, but some of the diagram locations of our intralesional injection is diagrammed, collected in a paper form. How is your data integrated in your pull data from electronic medical record, and it will keep separately from the TIL program from the rest of the electronic record?
Yeah, no, good question. How are we going to manage all this data? So right now, all the cell therapy is done on clinical trials, so that's a separate system for us. It's not, other than standard clinic notes, it's not really integrated in, and we have case report forms and different databases. But TILs is going to be standard of care, and so it's going into Epic. We are supposedly activating the EPIC research module. So there is going to be some better data sharing options. And I will say that I'll put a separate plug-in. So we do have the ability to share within the UC system. And so we have collaborative sharing with UCSF and UC Irvine, where Dr. Jang, I saw, is affiliated. So that's through a consortium where we can share data.
That's wonderful. So last question, if there's no more chat question. How are the follow-up visits arranged, or how are the patient being followed up after they survive the treatments?
Yeah, so it's because right now it's just been done on clinical trials, and so the follow-up's just within the team. But we anticipate with the commercial product that, so we use the cell therapy team, which, as I said, has advanced practitioners. And so once surgery happens, they will meet the cell therapy team, which has their own clinics and outpatient space. They'll go through the hospitalization and then come back out through the cell therapy team with another visit post therapy. But we're actually currently developing those educational materials for patients because, you know, modeling it off of, say, CAR T cells, those are different toxicities. Patients might experience neurologic toxicities 1 or 2 weeks later. There's restrictions on driving and things like that. But for TILs, honestly, once you get out of the hospital and your counts are recovered, you're back to kind of normal. Like you said, if you survive it, you're golden.
Yeah, that's true. We have our nurse call the patient after our injection to follow up on side effects each time, and then we also call them prior to them coming before the next dose to see if there's any reason to hold the dose or some wound care issue at the injection site. You know, Dr. Jang, do you have anything to add before we complete this discussion?
Just one question for Dr. Daniel. I heard about his previous TIL talks. He said that typically patient needs to have a size of a walnut of a tumor to be referred for TIL. Is that still hold true?
Yeah, you need about 1 inch of tumor. So yeah, something that's about 2 centimeters, not too necrotic.
Depends on how big is your walnut.
Yeah.
Yeah, so
And some walnuts are better than others. As far as, you know, you get better, or you get the efficiencies of making cells out of different areas from the body is different. And so again, skin tumors, that's ideal.
yeah, and easily accessible.
Yeah.
And I'll turn the discussion now to our last session to Dr. Andy Jang, our UCI professor. He will give us some updates on neoadjuvant clinical trials and followed by a led discussion.
Can you see my screen?
Yes.
Okay, great. Thanks, Dr. Su, to give me enough time so I won't have to talk too fast. Today, I'm going to go with some of the updates on the newest data for the melanomas. I try to go through 3 quick modules. Module 1 is resected stage 4 NED. What is after checkmate 238? Module number 2 is what is on TV today. Module number 3 is a single agent but different way in neoadjuvant. So let's move on. The first is that checkmate 238. This one is really established high-risk stage 3B to C, and also the important part is does it include resected stage 4 patients, compare NIVO and IPI, which show that the adjuvant NIVO has a significant improvement in the relapse-free survival. 48 months RFS for nivo 52% and the EP is 41%. So this is really the first approved therapy in patients with resected stage 4 melanomas adjuvant. Now the problem is that is a part of the big trial. It wasn't a single prospective randomized trial. And now that comes to the Immunence study, which is the adjuvant nivo alone versus a combination of nivo EP. This is a prospective randomized double-blind trial. What we know is, again, Checkmate 238, the only approved therapy right now is the nivo. But there is no significant OS benefits when you compare nivo over EP. The combination therapy in adjuvant and Checkmate 915 did not really improve relapse-free survival compared to nivo. So this is the schema of this trial for the Immunence trial, which is a high-risk stage 4 resected patient, randomized 1:1:1. Basically, your standard nivo EP, nivo 1, EP3. This is not a flip dose. And versus nivo 3 and versus placebo. And basically the same fashion as what we used to do the nivo EP. The caveat is that this trial is allowed crossover in the placebo arm if there is a progression. Study-wise, you can see that they're fairly equal in patient selection and patient populations. But one thing I want to point out is you can see that the standard non-flip dose of nivo EP is actually not that easy to give. On average, in the nivo EP, most patients only got about 2 doses of nivo and 2 doses of EP. And you can see that there's also a high discontinuation in those patients. Premature termination is close to 78% compared to nivo alone, which is 59% compared to placebo. Now, despite all that, you can still see that there is a significant improvement in relapse-free survival in this setting. When you compare nivo EP to nivo or nivo EP to placebo, the curve is clearly separating at clearly at 48 months. You can see the RFS in combination arm is 64% versus nivo alone arm is 31% and versus placebo is 15%. You can see across the board, majority of patients, regardless of the PD-L1 status, BRAF mutation, A6, they all very favor the combination nivo EP versus placebo. The overall survival, I think there's only 36 events happen with 160 patients of the intent to treat population. So really, the overall survival has not been reached because of a lack of events. But you can see that the hazard ratio is actually impressive with a nivo EP compared to placebo of 0.41. Now, so this is really the first prospective randomized placebo-controlled trial in the resected stage 4 melanomas, and basically show that the nivo plus EP and nivo continue to show significant improvement in RFS versus placebo. And the 48 months overall survival rate was 84% for nivo EP, 73% for nivo, and 63% for placebo. So basically, this result supporting the use in combination of nivo EP as the adjuvant therapies in resected stage 4 melanoma after surgical radiation. My module number 2 is going to be what's on TV today. Actually, I'm going to be talking about I'm sure the patients start to come in to talk to you about what's, they say something very promising for melanomas, vaccine therapies. Actually, the data was just presented in AACR actually last week. But I think that we already knew that this Keynote 942 already made their endpoints. Actually, the data was so new, some of the slides I'm going to show, I just got it today. I just want to let you know this is really off the press, so to speak. So the Keynote 942 is a phase 2b trial. It's a messenger RNA 4157 in combination with pembro. versus pembro alone in resected high-risk stage 3 and stage 4 melanomas. Now, what is this messenger RNA? It's a single messenger RNA coding for up to 34 neoantigen. I think thanks to the COVID pandemics, that we really, accelerate the technology in single messenger RNAs. And this is tailored to patients' unique DNA mutation signatures. So basically, you had to take the patient tumor and do the NGS testing, and basically come up with their own neoantigens, and you're able to prime the immune system, and you get a tailored anti-tumor response. The study design is it had 157 patients and 2-to-1 randomization, 107 patients on combination arm, 50 patients on the pembro alone arm. And again, the study population is high-risk 3-4 resected melanomas. The median age is about 60. They are mostly stage 3 patients, okay? So this is just a cartoon that kind of show how they do it. You do the NGS sequencing, patient's HLA typing, you collect the patient data, you look at their mutation, HLA type, and you select the neoantigen, and then you start to annulate the neoantigen features and able to make it the design messenger RNA sequence. And you can do it up to 34 neoantigens in individual patients. From what I heard, it usually takes 3 weeks or so, 3 to 6 weeks or so to get the products. So this is a general schema of this trial. Again, it's a 1 year of pembro versus 1 year of pembro plus the messenger RNA vaccine is 1 milligram IMQ 3 weeks for up to 9 doses. And the endpoint is recurrence-free survival. That's a primary endpoint. And the secondary endpoint is the distant metastasis-free survival and safety. The patient selection is you need to have complete resection within 13 weeks or prior the first dose of pembro. So suffice to say is most patients will probably get 2 doses of pembro before they receive the first shot of their vaccines because it takes time to manufacture. Cannot have a brain mets. ECOG is 0 to 1. Again, I say majority patient are 3C patient, but there are 22 patients at stage 4s. The result shows that there is a significant improvement in the recurrence-free survival. You can see that the 12 months RFS is 83% versus 77.1% in favor of combination pembro versus the mRNA. The 18 months is 78.6% versus 62.2%. I kind of put it into a table format here because I didn't think I was going to get the curve slide today, but that's kind of how it shows. 2-year recurrence or deaths in the combination arm is 22%. Pembro alone is 40%. And the hazard ratio is 0.54. So reduced risk of recurrence or death by 44%. Now there is a separate abstract that was done on Keynote 942 in the AACR. I didn't really get a detailed number on this, but suffice to say what they learned from this, they also look at the TMB in this as a subgroup analysis. And they were able to show that the RFS or recurrence-free survival benefit across both high TMB and non-high TMB group. So basically, TMB will not be a selection criteria, so to speak, in this treatment. So that's to me, I think the potentially a game changer in the future, using a complete different modalities and complete different new technologies in treat patients with melanomas. Moving on, my last module is a single agent but different way in neoadjuvant. So in the neoadjuvant space, we pretty much know that the IO is probably a preferred therapy. You can clearly see when you use the IO therapy as a neoadjuvant versus targeted therapy, the IO therapy is significantly better in terms of recurrence-free survival. So that's what people are thinking. The issue is really how do you incorporate it to the real practice. So the thinking about is, should we do the neoadjuvant versus plus adjuvant, or versus just the adjuvant alone? Or do you need to do anything further if a patient achieves a PCR after neoadjuvant? So the pivotal trial that was presented by Sanna Patel and Andy Anderson was the SWOG 1801. This is basically a very simple design. Basically, this is 1 year pembro, exactly the same frequency, same dosage. The only difference is in the neoadjuvant arm, patient get 3 cycles of pembro prior to surgery, and then followed by 15 cycles of adjuvant. Very simple design, 1-to-1 randomization. And about 150 patients on each arm. And the endpoint really is that it significantly showed that event-free survival in favor of if you get patient with 3 cycles of neoadjuvant pembro, followed by surgery, followed by adjuvant pembro, versus just surgery and followed by pembro alone. It was a hazard ratio of 0.58. 2-year event-free survival was 72% versus 49%. Now, what they also find out is, you can see that right here, the recurrence, melanoma recurrence after starting adjuvant therapy is 44 patients in the adjuvant setting. So what they try to say is, majority of the event happen in the adjuvant setting, whether it's in the neoadjuvant arm or whether in the surgical followed by adjuvant. Related adverse event is really no difference. Neoadjuvant pembro did not increase adverse event in perioperative period. So the bottom line is we did not learn any new signals in this study. Finally, so the summary is event-free survival was significantly longer in neoadjuvant arm than in the adjuvant arm with a hazard ratio of 0.58. And the 2-year event-free survival was 72% in the neoadjuvant arm versus 49% in it. Key thing is no new safety signal was identified. So in conclusion, basically the SWOG 1801 demonstrate compared to the same treatment given entirely in the adjuvant setting, neoadjuvant pembrolizumab followed by adjuvant pembro improve event-free survival in resected melanomas. Thank you. That's really all the data that I have. Then we can maybe open up to discussions. I do have a few questions that I prepared. Maybe we can open up to some discussion. Either Dr. Su or Dr. Daniel can kind of chime in on this. The question one is, how does the data for KEYNOTE-982 affecting your decision in adjuvant therapy in resected stage 3 or stage 4, assuming its approval?
So assuming that the mRNA vaccine gets approved?
Yeah. I'm sure they're going to move on to the phase 3, but
yeah,
assuming they are approving, what would you?
It's kind of tricky, right? Because right now we're using neoadjuvant. The 44% RFS can be easily obtained or competed with at least if we just do the S1801 trial and then just move it to neoadjuvant, right? So without the 9 doses of vaccine and the fear of not able to get the commercial prepared vaccine, and you can just simply just move the timing of the checkpoint inhibitor to the neoadjuvant setting, and you get the same result, if not better, right? So that makes it tricky.
I think probably the next step will be neoadjuvant pembro or PD-1, and then followed by surgery and then the vaccine, because you would have had time to produce the vaccine. So, I think it'll continue to evolve to see.
Okay.
Hopefully we'll get to that point where we just don't need surgeons anymore.
Just for surgical biopsy to see if neoadjuvant works.
Yeah.
The second question is really is I presented both SWOG 1801 and also the immune data. One is a neoadjuvant approach in the potential resected stage 4 patients, and one's actually an adjuvant therapy in the resected stage 4. And they both show benefits. So how do you decide if you got a patient who's stage 4 but potentially resectable? You want to do a neoadjuvant approach, or you want to do a resection and followed by adjuvant nivo EP?
Well, for me, if it's stage 4, I'm gonna start with ipi nivo, even if they look resectable, just because again, I'm hoping that I can avoid surgery, because that's what the long-term data suggests for a stage 4. For a stage 3, I was hoping you'd answer this, because I feel like, one study, it's a good study, but it's still kind of a small study, and we don't have long-term data. So I feel very comfortable saying, I'm comfortable saying neoadjuvant's not worse than adjuvant, and it probably is better. And so that's how I present it to patients, that it's probably better. I would like to see some confirmation.
Yeah, I have no issue using neoadjuvant if in nivo. There's some unanswered questions with the immune data. It's good to know that EP nivo is safe to give and shows RF as a benefit. But if you go back to the forest plot, they're comparing it to placebo, and they show maybe some of the data is tricky to interpret because they compare to a placebo instead of the biggest question is it power to interpret like nivo IP compared to nivo single agent? It shows some trend, and also the BRAF, I believe BRAF positive patient showed a more definitive benefit from ipi-nivo compared to BRAF negative patient. And some subgroup analysis, but it's already, like Dr. Daniel said, it's a small study, and you subgroup analyze a small group of patients. Difficult to interpret.
What I meant was the neoadjuvant, Pembro study, because I'm reminded that we had a few years back, there was a study with neoadjuvant ipi-nivo versus neoadjuvant nivo. And it was felt, the interpretation from that study was it was not a good idea to give neoadjuvant nivo alone, because a fair number of patients progressed prior to surgery in that study. And so, but now we have, as you said, the SWOG 1801 says, nope, PD-1 alone is just fine. So that's where my hesitation comes. There is some conflicting data out there.
Right. And then the Prado data show the neoadjuvant ipi-nivo, and some patient only like they personalized approach in terms of the index lymph node, right? And the people who have a CR in the index lymph node just omit the adjuvant treatment. We're not ready for prime time yet with that personalized adjuvant approach, but sometimes maybe in some patients a neoadjuvant ipi-nivo is enough, a few doses. Yeah, so the immune data is interesting, but I have to kind of take it with a grain of salt, I feel.
I see. Question number 3, this is actually for Dr. Daniel, is how does the advancement of messenger RNA technology and this Keynote 942 affecting the future of TEL therapy? And that is something also when I asked you about the walnut size of a tumor. Because if I don't have a patient who has walnut size of tumor, maybe not eligible for TIL, perhaps I can just send a small amount of tumor and try to come up with a messenger RNA vaccine. So I kind of want to get your thought on how does all this messenger RNA thing affecting the future? Are they maybe synergistic, or maybe they can help each other, or what do you think?
Yeah. So a TIL product, the reason you need a walnut is you you have unselected diverse group of TILs. This is a thought, and it's stacked against multiple antigens. Interestingly, the mRNA approach, they're going after potentially 34 neoantigens. They're trying to predict it with a computer algorithm. So, they're not 100% effective. So they're probably, hopefully they're getting, a T cell response to maybe 25% of what they're actually trying to get at. That's not very many like T cell clones. And I think it's interesting. But it's very different than how TILs are presumably working, which is a really broad, diverse response. So where they could intersect, people have looked at trying to improve the efficiency and response in the tumor prior to harvesting. So you can think of doing TVEC injections, for example, into the tumor first and trying to get the cell infiltrate, and then, harvesting that and then making the product. You could think about, the thing about RNA is it's really immunogenic. And so that's why the COVID vaccine works. You could inject, and Moderna was doing this prior to the COVID outbreak. They were using their mRNA technology as really an adjuvant, combined with different checkpoints. And we're about to open up a series of studies when COVID hit, and they flipped over to developing this vaccine. Now they're coming back to cancer. So they have a lot of technologies that could stimulate an immune response beyond just the vaccine part of their technology.
Last question. Although I didn't present the second bit data, but that's in the metastatic setting. But we know the DREAMseq data. The IO followed by BRAF is better in OS versus the reverse sequence. But in the second bit data, as you know, that they including the third arm, which is a sandwich arm. And the data appear to be just as good compared to the standard IO followed by TKI arm. So I just want to ask Dr. Su, Dr. Daniel about, does the data from the second bit trial, changes any way or shape, or you thinking about treating BRAF positive stage 4 melanoma first line?
Sherry?
Yeah, that's interesting. And also they added biomarkers, right, as a part of the secondary endpoints.
That's correct.
Second bit trial. The BRAF positive is tricky because in the beginning, in the DREAMseq, you see a drop of the curve, disease progression-free survival curve in the beginning, and then kind of catch up and become better on the IO arm. So, those patients that did not do well when you started IO combo therapy, could they be salvaged by target therapy is always an interesting thought, right? So I don't know if we have the answer to this, So I would say if a young patient with rapidly progressing disease, I have a tendency of starting, in those patients, a very small group of patients, the target therapy and think about transition when the disease are fairly controlled to immunotherapy to give them the opportunity of achieving durable response. That sounds attractive, but I don't have data to support this.
Yeah, and I agree. I think that's reasonable. I think what Succumbit taught me was that you can get away with giving 2 months of targeted therapy and still keep your response to immune therapy. That's what it looks like to me. But I still, even in those rapidly progressing, if they can tolerate immune therapy, I still start with immune therapy. But they bail out and use targeted if they get into trouble, and then I switch them back to immune therapy. That's kind of how I approach it. But
Good. I mean, that's really all the question I have so far. I can open up to discussion for anything further.
yeah, we're a small group, so if people have questions.
Hi, guys. Can you hear me?
Hey, Derek.
Hi, how are you? Probably a basic question for you guys. Are there any patients you would consider for the alternative Ipi-Nivo dosing, Ipi-1, Nivo-3, or is that based on the fact that we don't know that it's non-inferior, is that really something we shouldn't do?
Yeah, you're going to get 3 opinions out of 2 people. Because like you said, for those that don't know, the response rates look pretty darn close, but we just don't have that long-term survival. But clearly the toxicities are lower with the Ipi-1, Nivo-3, or renal cell dosing or flip dosing. My bias is if you look like you're a good candidate for dual checkpoint, you're getting Ipi-3, Nivo-1. I though will switch over to Ipi-1, Nivo-3 if I start getting into trouble and it was a mild trouble and I didn't have to put them on steroids. I'll flip them over, but it's unusual for me to start there. Just as I struggle too with, we didn't talk about Opdualag. Where do you place that now as a frontline dual checkpoint? And in my mind, that's what it's competing with. It's either, am I doing Opdualag or am I doing flip dosing? And even there, my bias would be actually to do flipped dosing rather than Opdualag. And that just comes from my biased view that Ipi is providing more diversity of response and potentially more long-term control. And also I can get patients off treatment faster with flip dosing Ipi than Opdualag. So I use Opdualag in the second, third kind of line setting. Mostly use normal dosing Ipi-Nivo. Sherry, I don't know how your practice is.
There's a certain population that definitely tend to use the regular dosing, the original dosing, which is Ipi-3, like a patient with brain mets, because of the long-term data. And in a young patient who has a pretty good performance status and can handle the original dosing, but in a patient with a poor performance status and kind of frail, I can do flip dosing. I struggle with the Opdualag where to use it as well. Just to remind me, is the Prado neoadjuvant use the original dosing as well? Or yeah, so that's in the neoadjuvant setting, that's the original dosing, 2 doses of right, the Nivo-1 Ipi-3. Dr. Jang, when do you use the flip dosing?
Dr. Su knows my position on this very well.
Yeah, third opinion.
I'm the only one here is I'm adamantly do not flip the dose. The reason why is I always like, I don't think anybody will argue that if you have a toxicity, you may have a borderline performance status, you might have to dose reduce. There's no question about that, right? But if you got a patient who's first line, first dose, and a good performance status, I don't really see a good reason to flip the dose. Because none of the data can give me a 7-year durable survival data. I don't care how you squeeze it, if you talk to different experts, they all have their different opinion. But at the end of the day, again, you show me a 7-year overall survival, and then I'll buy it. So I'm very firm on this. I do not flip the dose unless there's toxicity or there's a reason. But I will do the standard route to kick off.
And there's the other side of the coin too. It's like more cowbell. Do we need more Ipi? Because some of the other earlier studies when we only had IPI to play with, right? They played with 3 different dosings of IPI, and they landed on 3 because it looked like it was the perfect balance between response and toxicity. But at 10 mg per kg, you actually got, when that data finally matured, an overall survival benefit for 10 mg per kg over a 3 mg per kg IPI exposure. So it's, I think, there's some personalization that needs to happen, because we all have that IPI-NIVO patient that went through and had 0 toxicity. And usually they have 0 response. So did they need more IPI? We
I
don't
can
know.
only say, thank God, Kaiser Riverside, we have not done a 10 mil in EP in our setting because it's very
Didn't
toxic.
you enroll in a clinical trial, the 10 milligram?
Yeah,
And I'm the one who's had to run in the hospital.
Yeah, not for everybody.
Yeah. Yeah. All right. Thank you, Eric, for the question. Anyone else has any question or in the chat? Let's see. No.
I don't see any in the chat,
Yeah.
but last chance for any questions. Feel free to unmute your line if that's easier than typing it into the chat. While we wait for any last minute questions to come in, thank you all for presenting that information. That was a lot, but very good information. And we appreciate you taking the time out of your busy schedules to be here with us tonight to provide this. I don't see any questions coming through, so I will go ahead, and this concludes our webinar for tonight.
Thanks, Nicole.
Thank
Thank
you.
you so much.
Thank you.
Have a good evening.
Right.
Bye-bye.
Bye.